Welcome student, we have started scenarios discussion on the hepatobiliary system from the GIT surgery, and in which we have discussed scenarios on gallbladder cases as well as on pancreas. Now coming towards the liver. In the liver, we will discuss our first scenario, and today our first scenario is a 45-year-old shepherd. A 45-year-old shepherd present with Portman history of pain and swelling in the right hypochondrium. Pain in the right hypochondrium as well as swelling in the right hypochondrium. Ultrasound shows cystic lesion in the right lobe of the liver. Cystic lesion. There is a cystic lesion in the liver by ultrasound in a shepherd, and it is associated with pain and swelling. Now we know that there are two type of swelling that occur in the liver. One is amoebic cyst and other is hydatid cyst. As the patient is giving history that he is a shepherd, he is working in a shepherd grazing area, and he is giving a prolonged history of pain and swelling with no history of fevers and rigor. If there was a history of fever and rigor with pain with cystic swelling, then our diagnosis will be amoebic cyst. But in this case, as the person is a shepherd and he is not giving any history of fever and rigor, he is giving only history of pain and swelling and cystic lesion, then our diagnosis in this case is hydatid cyst. Our diagnosis in this case is hydatid disease of liver. Hydatid disease of liver. What is the causative agent of this disease? What complication the patient can develop, and how we are going to investigate and treat this patient? The causative agent is Echinococcus granulosum. It is a tapeworm. Echinococcus granulosum is a tapeworm found in the sheep grazing areas, and this tapeworm has definitive host as well as intermediate host. Definitive host and intermediate host. In definitive host there is a dog, while intermediate host include the human and the sheep. In definitive host, the organism enter into the dog intestine and gives lay eggs, and these eggs then excreted in the feces. While these the human are infected by the feces of the dog in the sheep grazing area. The human then develop the cystic lesion in the liver, and this cyst contain larva of the echinococcus. And the shepherd are also infected. The shepherd, while eating grass which is infected by the dog feces, develop the cyst in the shepherd also develop the cyst, the hydatid cyst. And this cyst in the this cyst from the shepherd meat again eaten by the dog, and the larva in the dog intestine develop into adult worm and again give lays egg, and this cycle continues. This was the agent, and the dog, the worm enter into the intestine, lay eggs, the eggs excreted in the feces. The eggs excreted in the human are infected by the feces of the dog directly, as well as the sheep are infected by the feces, and hydrated cysts develop in the liver of the human as well as the sheep. Now what complication the patient can develop? This cyst in the liver can this is suppose this is a cyst in the liver, and this is the portal vein which brings the blood from the mesentery and from the intestine and from the visceral organ towards the liver, while this is the inferior vena cava which brings out blood from the liver to the superior vena cava and to the right side of the heart. These are the hepatic veins. If this is developed in the liver, this can this can develop some pressure symptoms on these organ. This can pressurize the portal vein. When it pressurize the portal vein, it can result in portal vein hypertension. in portal hypertension. And in portal hypertension, back pressure will be increased towards the esophageal veins and towards the splenic veins. This can also pressurize the hepatic vein, and in the hepatic vein, the cyst, when pressurize the hepatic vein, it can result in Budd-Chiari syndrome. Now, what is Budd-Chiari syndrome? If the endothelium of the hepatic vein get pressurized by the cyst, the endothelium will be injured, and there will be activation of the clotting system, and a platelet rich clot will form in the hepatic vein, and this thrombosis in the hepatic vein is called Budd-Chiari syndrome. This cyst can also pressurize the inferior vena cava and can increase the pressure of the inferior vena cava. The local complication in the cyst are infection, abscess, and this can rupture into the peritoneum. If it rupture into the peritoneum, it can cause peritonitis as well as can result in anaphylactic shock. And if it rupture into the biliary tree, this is the left hepatic duct, and this is the right hepatic duct, and these two combine form the common hepatic duct. This is joined by the cystic duct, and after cystic duct joining these hepatic duct, the duct is called the CBD. When the cystic duct join the right and the left and the common hepatic duct, then the duct is called the CBD. And in this CBD, when the cyst rupture in the biliary tree, when the cyst rupture in the right and the left hepatic duct, in the right hepatic duct and the left hepatic duct, the fluid of the cyst will come into the common hepatic duct, then the fluid will come into the CBD. This is the cystic duct and this is the CBD, and in the CBD it will cause obstruction of the CBD, due to which obstructive jaundice will result. So the complications are portal vein hypertension, Budd-Chiari syndrome, inferior vena cava pressure syndrome, obstructive jaundice, anaphylactic shock and peritonitis, infection, abscess. These are the complication of the cyst. Now, how will we will investigate this patient? We will first do ultrasound. It is an initial investigation of choice which will show us the cyst. We can do CT, which is the investigation of choice. It will show about the involvement of the other organ as well as the pressure symptoms and the anatomy of the whole liver. Then we can do CBC. In CBC, we will look at the eosinophilia, because eosinophil will be raised because of the parasite inside the body. Then we will measure the serum antibody. The serum antibody will develop against the hydatid antigen. The echinococcus antigen, against the echinococcus antigen, the antibodies will develop. Then we will do treatment. In treatment, the surgery is the most effective treatment, in which there are basically two surgery: conservative surgery. In conservative surgery, we basically open the cyst, remove the roof of the cyst, unroof the cyst, and then omentum is placed in the cyst to the fluid is aspirated. And omentum is a plate of omentum is placed in the cyst to maintain the blood supply of the area and to re-epithelize the normal liver tissue in this area. This is not a most effective treatment. This can lead to recyst formation or can lead to any abscess or fluid collection. In the second surgery, we do radical surgery. In the radical surgery, we do complete cystectomy. We can do two type of surgery in the radical surgery. We can do pericystectomy, in which the cyst along with its capsule is removed, or liver resection. In liver resection, we remove the cyst as well as some normal area of the liver, some normal tissue of the liver surrounding the cyst. This is the most effective treatment. In the medical treatment, we can give albendazole to the patient and mebendazole to the patient. Albendazole is given 10 milligram BD twice a day. BD twice a day. BD means twice a day. It is given twice a day for 3 to 6 months. 3 to 6 months. Albendazole or mebendazole is given for 3 to 6 months, 10 milligram and 2 times a day. And then we can do percutaneous treatment. In percutaneous treatment, we can do, first of all, we can do a puncture. Then we can aspirate the content of the cyst. Then we inject a solution called prostrocidal solution. Then we inject prostrocidal solution. This is a solution to kill the prostrocytes of the Echinococcus granulosum. What is the prostrocyte? The prostrocyte is basically the larva of the Echinococcus granulosum. It will kill the larva. It include normal saline. It include cimetidine. It will include povidine iodine, and it also include chlorhexidine. And these the normal saline, the cimetidine, and the povidine iodine kill the larva of the Echinococcus granulosum, and then we can again re-aspirate the fluid from the cyst.